All right then, good afternoon everyone. I'd like to start. My name is John Rother. I'm the President and CEO of the National Coalition on Healthcare. And first I want to thank you all for coming today. This is an important day for us. It's a day when we are shifting out of an election campaign mode into a serious effort to confront the challenges that we face as a country, and there's no challenge greater than the challenge of keeping our healthcare system affordable. That is the mission of the National Coalition on Healthcare, and we're today releasing a series of recommendations that we believe would move us toward a more sustainable, more affordable healthcare system, both in Medicare and system-wide. Now, first, I want to welcome the members of our board of directors who are here. Our board chair is George Deere from CalPERS, who will be speaking shortly. Our board treasurer is Cheryl Mathias from AARP. We have Jack Lewin, who's former CEO of the American College of Cardiologists, also speaking later, and Joe Menerick from the Committee for Economic Development. And it's especially important that I recognize them because the board was the body that made the decision to go forward with this set of recommendations. I'm going to explain how we got there in a second, but I think that they will have opportunity to answer questions or make statements after we do this. I want to explain the rationale and goals of our efforts. And then I'm going to share the 7 key strategies that we are recommending that would help keep health affordable and would help improve the value of our healthcare dollar. And then after I'll speak, you'll hear from 3 different perspectives: a purchaser, a health provider, and a consumer. And that's our panel here this morning, or this afternoon. And then we'll be happy to take your questions and get any feedback before we wrap up at 3 o'clock. So if everyone's ready, let's get started, because we do know that healthcare costs are among the most serious challenges we face as a country, but they're also challenges that we face as families and as businesses, and at the state level as well as the federal level. Healthcare costs are the single greatest economic challenge we face, but they're also a moral challenge, because healthcare, after all, is about life and death. It's about quality of life. It's an expression of how we care for each other. And so how we manage these issues is really a profound challenge. It's not just about saving money. It's about how do we make a system that's more responsive, more person-centered, and ultimately more ethically solid than the one that we have today. Now, the National Coalition, for those of you who are new to our efforts, has been around a long time. We're over 20 years old. We're the largest coalition in the healthcare world. It's basically purchasers, providers, and consumers. And after the enactment of the Affordable Care Act, we decided that we needed to really focus like a laser on affordability. And so that's what we're doing today. We're trying to focus on how to keep healthcare affordable, how to keep our healthcare system sustainable, not just for government, but for all of us. Now, I have to say at the start that not all of our members, we have 80 organizations that are members, not all of them agree with every element of the plan. In fact, I'm sure that you'll find some who disagree with specific parts, but I think you will find that members feel that this is moving us in the right direction and that there's broad support for the kinds of strategies that we're recommending. This is also a dynamic effort. It's something that may change as we go forward, because we're still learning about what's working well in healthcare system. And there's a lot of things that around the country that we are learning from and that are working well. We're learning, for example, that good healthcare is often less expensive healthcare. Doing things right working with patients, working in teams is often the way to maximize value. But we also learned that there's no silver bullets here. There's no one thing you can say. There's no one catchphrase that's going to solve this problem. Just cutting reimbursements or cutting benefits or narrowing eligibility by raising the age is not solving the problem. It's shifting costs, or it's so blunt that it could make things worse. So what we're about is trying to promote policies that are better targeted, that would actually improve care and lower costs at the same time. So how do we do that? We know that real change is possible, that these innovations across the country sometimes are working quite well. And we know that if everyone, all stakeholders, are open and willing to change their own behavior, we can solve this problem. But it does take an openness to change, a change by purchasers, a change by providers, and a change by consumers and patients if we're going to be successful. Now, our policy package is built on the examples that we've gathered, and it's designed, our recommendations are designed to achieve two separate but related goals. The first is we are trying to recommend ways to reduce the federal deficit by almost $500 billion over the next 10 years in the healthcare arena. That's ambitious, but I think it's also realistic given what Congress is likely to face in terms of the federal budget. But it doesn't stop there, because many of the things that are most important longer term to change incentives, to change health delivery, to change behaviors, are not easily scorable by the Congressional Budget Office, or they take a long time to come to fruition. But we've included those ideas in our recommendations because, frankly, we may not get another chance. As part of the deficit package, it's important that it not just be about the deficit, but that we also include ideas that we call game changers that really can transform the way healthcare is delivered. Now, I'm not going to go through all the specific recommendations here. They're available to you in the package or online. We've done our homework. We have very specific recommendations backed up with footnotes, with cost estimates where they've been available and credible, and I urge you to take a look. But what I'm going to do now is simply summarize the 7 key strategies that these recommendations are based on. So the first strategy, and perhaps the most fundamental, is to change the way physicians are paid, to move away from fee-for-service, to move away from paying for volume to paying for quality and outcomes. And if we can do that, then everything else is possible. And if we don't do that, it's going to be very hard. So a change must begin with the repeal of the sustainable growth rate and putting in place a new strategy for physician payment that transitions Medicare providers away from today's fee-for-service system toward value-based models. We have bipartisan proposals in the Congress that are designed to do that, but that is a fundamental building block for the kind of change that we need. Now, the second strategy is to engage all of us as consumers, as patients, in the kind of engagement in our healthcare that we need. And I don't just mean choosing a doctor or being able to email about when your next appointment is. I mean really helping people understand what's needed to stay healthy and what they need to do as their part. And I'm talking, of course, about diet and exercise, but I'm really also talking about things as simple as taking your medications as prescribed. Because when people don't do that, they end up in the hospital. So we have to have a way to get people more engaged in their own care. And that means to be more transparent. People need to see what the cost and the quality is and what choices they have. Now, a third strategy is to do a better job of harnessing competition as a way of making pricing more efficient. And we have some beginnings of that now in Medicare, and the durable medical equipment is working pretty well. We think we could broaden this to encompass more categories, and we think we could encourage greater competition in state healthcare markets as we move toward implementation of the exchanges. We also think we have to watch out for monopoly and monopsony situations where competition really is not possible because of market power concentration. We think we could do a better job of expanding competitive bidding as an alternative to administrative price setting. And I think we could remove additional barriers to generic drug competition. Fourth strategy is to improve the value of care for those patients with the most complex medical needs and the highest costs. These are often frail elders. They are patients with multiple chronic conditions. They are people with serious mental illness. They're people near the end of life. The sickest 5% of beneficiaries account for half of total healthcare spending. Often that the care they receive is fragmented. It's not optimal. We need to really focus on being more person-centered to deliver care people need and want in a way that is likely to produce better outcomes for them. And we are convinced that when that happens, it will also lower costs. So it means increasing access to coordinated care models. It means making sure that we've promoting models of care that are particularly suited to diverse populations. And it means that patients facing serious illness have access to palliative care, not only at the very end of life, but throughout. Because we know that when people are more comfortable, they're less likely to demand futile care. Now, the fifth strategy is to bolster our primary care workforce. Today in the United States, we are overly reliant on specialists, and we are under-resourced when it comes to primary care. So yes, we do need to train more physicians in primary care, but we will never have the resources or the time to train enough physicians in primary care. We have to use nurses, we have to use social workers, we have to use physician extenders who can work as part of a team to deliver better primary care. We know that where the person-based medical home has been implemented, it does an excellent job, not only improving care, but again, lowering costs. So that means if we're going to move in this direction, we've got to address restrictions on scope of practice and things like that that get in the way of using people to the fullest extent of their ability to deliver the care that people need. Now, a sixth strategy is the good old one of going after excess administrative costs, fraud, and abuse, medical errors. Now, we can do a lot more than we are currently doing to combat fraud. We can put more resources into that effort, and we know that that would generate a very positive return. But this is not just about going after the bad guys. This is also about reducing the current incentive for physicians to practice defensive medicine because of the fear of malpractice suits. The malpractice system today is not working to compensate those who are injured. The people who benefit from it are not the people who should be benefiting from it. those people who are hurt by errors, and we can do a better job. So we are proposing 3 new ideas as a substitute for our current medical malpractice system, ideas that we think would substantially improve outcomes of care, reduce the incentive for defensive medicine, and therefore also reduce costs. Now, the final strategy has to do with prevention and population health. We know that today we face an epidemic of chronic conditions. We know that we face right now a huge increase in the rate of obesity in the population, huge increases in hypertension, other chronic conditions. And frankly, I don't think we're serious enough about trying to turn that around. Information alone does not seem to be very effective in changing behavior. Changing the price of harmful things does seem to be effective in changing behavior. So we are recommending that we increase excise taxes on harmful substances that lead to greater healthcare costs. So that means tobacco, that means alcohol, and that means sugar-sweetened beverages. Now, these raise revenue for sure, but the main point is that they will deter consumption. They are an important signal to people to consume less, to take better care of themselves, and hopefully over time to reduce the burden of these kinds of diseases on the healthcare system. So let me just conclude by saying that the campaign's over. It's time to face up to some pretty serious challenges. We know that healthcare is going to be a focus of this debate. Our goal here is to put what we think are some positive ideas on the table for policymakers to consider. We know that some of the ideas that have been considered in the past we do not think are moving us in the right direction, so we feel the need to put something on the table that does move us in the right direction. We know that this has to find broad acceptance. We think that while I'm sure there will be organizations that object to one or another of these, that the fact that the National Coalition represents a broad coalition of stakeholders and that the leadership of that coalition found this set of policy recommendations acceptable is really an exercise of leadership. We're trying to lead the debate. We're trying to say, okay, we're all going to have to give a little. This is shared sacrifice to some extent. But the fact that we can do better by improving care and saving money, and now is an opportunity to do that. So I'm looking forward to hearing from my colleagues now who will comment on this. First, George Deere from CalPERS, then Jack Lewin, who is the CEO of, or former CEO of the American College of Cardiology, and finally Deborah Whitman from AARP. Thank you.